Sandra as an astronaut and myself as a fighter pilot, we lived very operational lives. And to us, what you do is like the cutting edge of being operational in the medical world. So, you're never quite sure what you're going to be faced with from moment to moment. What's that like? How do you manage the risk and uncertainty, not knowing what's walking in the door in 10 minutes?
Well, that's part of the fun of it is you don't know what's coming in the door. So you never get, you do get bored when things aren't happening and you're just sitting there at 3 a.m. and twiddling your thumbs, but you learn to recognize, let's enjoy this boredom while we have it. Fun fact, and I'm highly jealous of Sandy there because I wanted to be an astronaut growing up. And I even applied for their 2013-ish astronaut call when I was moving to Houston. And I was like, if I become an astronaut, I'll be in Houston. If not, I'll just work an ER job. And so I did not pass. So I completely failed at that. And I'm just going to name drop one guy named Johnny Kim. I don't know if you know him or not, but we like to call him amongst my circle of friends, which includes some faculty at Harvard, an emergency medicine residency dropout. But this guy's like a Navy SEAL and now an astronaut. And I just was liking some of his photos on Instagram from ISS. So yeah, this guy makes all of us feel really inadequate.
Just goes to show, if you can't hack it as a doctor,
exactly.
If you can't hack it as a doctor, you might end up being as a Navy SEAL or an astronaut.
Yeah, I think it's similar to probably what you guys train on as well, right? If you're a pilot, you got to be ready for certain emergency situations to take place, and so you simulate a lot of that stuff. Same thing, with space flight, right? You have to be prepared for the worst case scenario, and I think that's what emergency medicine does really well is we prepare for the worst case scenario. So the other day, I had to perform sort of a life-saving procedure on somebody, and it's something that I would say I'm prepared for, but I also feel like I'm halfway prepared for it as well, because of the fact that I work at a place where you have so many helping hands. Sometimes you get comfortable realizing that you're going to have help around you, whereas, let's say, emergency docs in rural environments have to do so much more because they don't have that backup there. And for us, I think being prepared for this is really important, that you focus on certain critical procedures that you have to do that are timely, that can't be looked up. A lot of medicine, I hate to say it, can be Googled. Now, not by ordinary lay people. It can be Googled by people that know what they're doing and are trained to do it, but just need a refresher before getting it done. But there's certain things where you don't have time for that refresher, and those are the things that you really need to train on, so that it's almost as hands-on, like riding a bike, kind of like memory, that sort of thing, physical memory, as opposed to having to think about it.
Many of our listeners have seen the TV series The Pit. I watched it, almost continuously through. It was so interesting to me. The layman, as you mentioned a moment ago. How realistic were the emergency room presentations in that series, in your view? I don't know if you had a chance to watch it.
So I have to admit, I've never seen an episode, but I did watch some scenes of it because at our emergency medicine conference this past September, Noah Wiley came in to talk to us with Joe Sachs, who's an emergency physician that works on the show, and they showed some scenes from it that were amazingly realistic looking, I would say.
I don't know how they did it. It's incredible.
Well, they explained to us, and it's the art of filmmaking and sort of having good sort of models and I guess I don't even know what you call these things, but it's just like the makeup department and everything can do their work so well that when they're showing a person's face and then pivoting down because they show like a baby being delivered. They essentially had it done in such a way that you think that it's real, even though what you're seeing below the belt is fake. So it's very interesting how they can accomplish that. And I think it went to show the level of detail that they have and that the creators of the show have in terms of getting it right from an accuracy standpoint, which is not easy. There are other movies and film that I've seen where they say they have a throwaway line. And one of my favorite ones to be annoyed about is in one of the X-Men movies where they claim that a person received a medication that made them appear dead. And it's not even the right kind of thing that you would use. I'm like, this is a blood pressure medicine. It's not going to do anything. This is a diuretic. It's not going to make you appear dead. At least, like, could you just call me on the phone and I could give you some options to make it sound better, as opposed to just randomly pulling some drug off the pharmacopoeia.
Well, I can tell you there are some cringeworthy moments from the Top Gun movies, but it's still a good movie. I
imagine like
still a good
watching
movie.
Like Top Gun or something. Yeah, I mean, I'd imagine that those things would look like, from your perspective, like extraordinarily difficult. This is why I can't watch The Pit right now, because I'm like, I do this all the time. I don't want to like be put back into that thing. So instead, I watch the space movies.
Okay.
And stuff like Top Gun. I love it.
When you do watch The Pit, send me an email and tell me what you think. But one of the things I wanted to ask you about in that series, and I told Sandra I was going to have this follow on, is one of the premises is, the dramatic themes is like a brand new crop of residents shows up, on that day in the operating room. And what they progress through, and without being a scene stealer, a mass casualty event, where they're actually doing tracheotomies and all this kind of thing. It would seem to me that a resident is pretty much doing baby steps, and that there is a decent progression, or are you just thrown into the mix right away as a resident?
It's a little bit of both. I mean, I've journaled when I started residency, and I remember reading back, and I was like, it feels like I was just thrown into the deep end of the pool. So to some degree, yes, you're given a lot of responsibility that you don't necessarily feel ready for. Then at the same time, I think the way we design medicine it is graduated responsibility. We're not going to go ahead and give the person that's a one day
wonder,
doctor the knife to do the crike.
Yeah.
So again, like when I was mentioning, it's the sort of the life-saving procedure that we were doing. It was like an ED thoracotomy the other day. I'm working with an upper level resident, and our surgeons were not yet downstairs. And we needed to get started on that procedure. So I'm there, standing there, and I'm telling the resident, go ahead and cut. We start doing that. And, to a degree, from my view, it's like she looked like she knew what she was doing and all of that. And then, a couple hours later, we're sitting in our room furiously typing notes, because that's what modern medicine has turned into. And she's talking about how her hand was trembling and doing all this. And I was like, wow, I didn't notice it. But like, I remember being a fresh attending out in practice, and every time I would code somebody or do CPR on somebody, my hands are trembling too. And to the point, like nowadays, it doesn't happen anymore. But that's something that you really, that's part of the training, I think, too, is sort of overcoming that nervousness when crazy things are happening and being able to suppress that. There's this book called The House of God, which if you've never read, one of the famous quotes from it is, if the first thing you do when you walk into a code is check your own pulse. I think it's just kind of goes to show, keep yourself calm in those situations.
I had to do medical training, for one of my training, they kind of did some EMT stuff, and it was harder for me to take somebody else's blood than my own blood, because I was sticking it with a needle. Like, I'm sorry. But to circle back for your training real quick, who decides what procedures you're going to practice, and how do you guys do simulations? I mean, because you don't really have a patient, do you, when you're doing simulations?
Well, so that's that part is heavily negotiated between emergency medicine and surgery in certain places as to who does what procedures on like real patients and everything. Typically, the way we have things set up on our shop is the surgeons get the left half of the body if we need to do a chest tube or thoracotomy, because that's something that realistically needs a surgeon's touch. The right side, if we need a second chest tube, we usually have that available for the emergency team to do. Airway, back in the day, it might have been an anesthesiologist. In most places now where emergency medicine exists, EM takes that. The rules we have set up for that is the emergency medicine resident gets the first shot. If they miss, I get the next shot. If I miss, the anesthesiologist is right there over my shoulder in these very serious cases to get it going. And then recently we had someone that was going to be a terrible, terrible airway, and the anesthesiology attending was standing there next to me, and we're talking about it, and we're like, you know what? You just do this one. Because the plan that we needed to do was something beyond the level of training that I felt perfectly comfortable dealing with. And I think we all worked collaboratively in that situation to get it done.
And you're trying to balance, I would imagine, training with the best interests of the patient as well. I mean,
exactly. No, I think that's what it's really about is you want to be able to train people, because if you can't train people, then the next generation isn't there for you when you need it. But then at the same time, you have to have adequate backup so that if things get difficult, that the highest trained person can handle it, that sort of thing. And to get to the point of how do we train, there's a lot of simulation. Simulation can be done on models or mannequins. Sometimes we have a cadaver lab. And so, people that donate their bodies to science, you can do these kinds of procedures and practice in that situation. So you can at least see what the anatomy looks like and all that. It's very different in a live human being where there's blood and everything that's pouring. So that's, the difficulty when you translate from mannequin to cadaver to live person.